To move to rounds of questions, we're going to begin with the Conservatives for 6 minutes. Dr. Ellis.
Thank you very much, Chair, and thank you to the witnesses for their patience. Dr. Koivu, I listened carefully to your opening statement, and one of the questions that I had was, when we look at the patients, a couple of whom you described, we're really not offering them any other therapy other than opioid therapy. Perhaps other things in addition to it, but just for the sake of those listening at home, we all know that people who take opioids will eventually get habituated or used to the dose they're on, requiring escalating doses. And if that's the kind of medicine that we're going to provide, is it not that fair then to say that we're providing these folks with palliative care?
Mr. Chair, thank you for that question. Absolutely. That is one of the significant problems with opioids is as you take them, your brain has changes in your neurochemicals that what you're taking, your brain becomes used to, and that becomes your normal. So to get the same effect, you have to increase the dose that you're taking. So to get the same euphoria, you have to continue to increase the dose. But perhaps even more importantly, when your brain readapts to this new level of that's your normal, you have to be taking opioids. You have to be taking them. And if you miss them, then your brain will miss them, and you go into what's called withdrawal. And withdrawal is a horrific experience where you get severe pain, anxiety, nausea, vomiting, diarrhea. You can feel literally like you're going to die. And then you keep thinking you need more and you need a higher dose. So whenever you're in a scenario where you're taking an opioid regularly, you're always chasing the high. Your dose continues to escalate. And you're always trying to medicate away from the withdrawal. And an important thing that isn't always mentioned that I want to add is that as your brain regulates and gets used to a certain amount of opioids, that's generally you tolerate that if you're well. If you develop a pneumonia, an endocarditis, or any other illness that affects your cardiorespiratory system, that same dose can be toxic or fatal. So when you're taking an opioid, you could be taking the same dose. You could be taking the same dose of your Dilaudid or your fentanyl. And if you develop a pneumonia, a sepsis, you will actually could become toxic from the same dose because your brain wants more than what your body can now tolerate. So when you are in a position of getting a treatment that's given to you daily to keep you going from one chasing withdrawal to another, it's not allowing your brain an opportunity for recovery. You are staying in a cycle in which you are absolutely dependent on the medication and can be at risk of developing tolerance, needing a higher dose, and needing a dose that eventually will be more than you can handle. And from the cases that I mentioned in hospital, patients were being prescribed substantially more than they could actually tolerate when we had them in a position where we could see what they were taking. And had we given them the amount that they were prescribed, it would have been fatal for them.
Thank you very much for that, Dr. Koivu. And through you, Chair, it's interesting that you started talking about dosages. So when we looked at patient one, I wrote this down, they had 900 milligrams of morphine and 320 milligrams of hydromorphone. Using an opioid calculator to kind of look at the overall dose of milligrams of morphine, that would be about 2,500 milligram morphine equivalents. Is that correct?
That is correct.
Thank you for that. And through you, Chair, again, looking at that for the average Canadian, again, doing the math, that's about 640 Tylenol 3. You don't have to trust me on that, but I used the same calculator to do it. And the reason I talk a bit about this is people often think, well, it's one tablet of 8 milligrams of Dilaudid. And I think that it's a bit concerning that for those who don't use opioids on a regular basis, that even though it's one tablet, it is still a significant amount of opioid. And maybe, Dr. Koivu, you could talk a bit about that.
One tablet is also equivalent to 4 Percocet or 20 milligrams of OxyContin. Those are doses that we considered fairly high during the opioid crisis. And taking 2 of them is essentially the amount that we would be considering would be, more like what an amount that would be considered a relatively safe amount for most people. 1 even can be considered toxic if you're not used to taking it. So when we're looking at the numbers that we're seeing, they're substantially higher than the milligrams of equivalent of morphine that I was seeing during the time when people were prescribing heavily for chronic pain. These are the highest doses I've ever seen.
And through you, Chair, very quickly, Dr. Koivu, if we talked about 2,500 milligram morphine equivalents, what would be the recommended amount, say that we would, a prescriber should really be very cautious in going over? And I realize this is a different patient population even than a usual chronic pain population, but what would be a guideline for Canadians listening out there?
Is 100 milligrams of morphine equivalent per day or less.
And these people are receiving up to 2,500.
Thank you.
Or more.
Or more. Thank you.
Thank you. Okay, we're going over to the Liberals. I have, okay, Dr. Hanley's good to go. All right, Dr. Hanley, you have the floor for the next 6 minutes.
Thank you very much, and thanks to all the witnesses for being here. I'm speaking today from the traditional territory of the Kwalendon First Nation and the Tanquichan Council in Whitehorse, Yukon. Dr. Hopkins, I wanted to address probably the bulk of my questions to you. Unfortunately, Chief Frost had to leave early during our vote, but in listening, I noticed you were listening acutely to her testimony and nodding. And I wondered if I might indulge, or if you can indulge me, was there anything in particular that resonated from Chief Frost's testimony based on your knowledge and experience as a chief, in her case, as a chief of an isolated northern community?
Well, we typically assume that the issue with resources and capacity to respond to the toxic drug supply is remoteness. It's geographical. And we are not asking for or expecting hospitals to be built in every one of our community. But the Canada Health Act says universal access to health care. And its objective is accessible health care without barriers to our wellness. And I mentioned this because there's lots of Canadians that live in rural and remote communities, but we are talking specifically about First Nations people. They have a right to access health care close to home where they need it. When it's not available there, then they'll go find it someplace else, which often draws them to urban environments. In urban environments, they don't always have access to the appropriate health care they need when they have opioid dependency or methamphetamine or other stimulants or even sedatives, like I said, benzodiazepines or, the tranq drug, which is not a controlled substance, xylazine. All of them have substantial effects on people when they don't have any healthcare resources close to home. And so that isn't just because of geography. That has to do with decision making. If the Canada Health Act says universal access to healthcare, no matter where people live, for every resident in Canada, then where are the policies that ensure access to physician care, prescribers, nurse practitioners, pharmacy, public health resources, harm reduction resources, where they exist for the rest of the population? Why are those not made available to Canadians, to First Nations populations, no matter where they live? Often it's referred to as a jurisdictional issue. Who's responsible? The Canada Health Act is clear. Our rights as defined in treaties, the Constitution, now the UN Declaration on the Rights of Indigenous People, do not erase our rights under the Canada Health Act. And so it's a decision a policy decision, not just because of geography.
Thank you. And if you don't mind, if I'll jump in because my time is limited, but one thing that Chief Frost referred to was having spent $1 million of base funding from the VGFN, in this case, base funding to send people out for treatment. I know I can't speak specifically to those, the number of individuals. I think she mentioned 70. But we do know that often when people go outside for treatment, they come back into a community. They are at high risk, not just for overdose, but for relapse, because the community supports the aftercare that isn't there. So in really following up on your previous point, what do you know of, or could you describe models of care that work within a small community? Maybe success stories that you know of or have seen about how care can be delivered within a community so that you have that continuity through aftercare.
Yeah, communities, no matter how big or how small, remote or isolated, who have partnerships with local health authorities, with physicians, with prescribers, nurse practitioners, who deliver services by flying into the community from time to time, or from monitoring their patients through video conferencing, where there's partnership with the chief and council, where there's direction through a band council resolution to how health services are operating through the health center. These kinds of partnerships with elders and cultural practitioners, together, it's clinical support and medication with culture-based resources that have made a difference. And I gave an example of a community in Northern Ontario where that significantly reduced the crimes, the kids going into child welfare, kids showing up in school with food in their stomachs, and houses being filled up with furniture and toys and food, and life returning to normal, because it's a whole of community approach, and because the community, through a number of partners, have the resources they need to respond to the whole of the population. It's not just the impacts on the individual who uses drugs, it's the impact on the family and the whole community.
Thank you,
Thank
Dr.
you.
Henry. That's your time. Monsieur Thériault, for 6 minutes, s'il vous plaît.
You have 6 minutes, Mr. Thériault. Thank you. Thank you to all the witnesses. Mr. Chair, I don't have any preconceived notions regarding the crisis that we're trying to understand. But when I hear different witnesses, I end up a little confused. There doesn't seem to be any scientific consensus. There seems to be a split in the scientific community. Dr. Pauly, you talked about safe supply and how it saved lives. I imagine that's the main goal. My first question is, should safe supply be temporary? And if yes, how do we assess how long it should last? Second question, why is there opposition between access to treatment through safe supply and opioid agonist therapy?
Thank you. These are two very important questions. And our team, I just want to speak for a second about the split in scientific evidence that the member referred to. And actually, there isn't a split when you look at what is considered peer-reviewed evidence or evidence that's been reviewed by multiple scientists in the field. Our team did a study where we looked at all of the evidence for safe supply. There's close to 40 of these types of peer-reviewed articles. And the evidence was overwhelmingly positive in terms of connecting people to a safer alternative, reducing overdoses, but also connecting them to healthcare and to other types of supports as needed, like housing and reconnections back to family and community. And I just kind of want to mention that evidence. And then in terms of should safe supply be temporary, this is a good question, because when it was introduced in British Columbia, it was introduced as a temporary measure. However, it became clear that we need it as part of a systems response. And I really want to emphasize this piece about a systems response. And in British Columbia, we've had some evidence early on that it's when we combine multiple interventions like take-home naloxone with opiate agonist treatment, with overdose prevention, that showed some really good results, but it wasn't enough. And so safer supply comes in as another form of intervention within a comprehensive kind of approach. And then your question about, why the opposition? I think that's I personally don't understand why safer supply is being scapegoated, because the real harms here are coming from a very toxic and unregulated drug market. That is what's killing people.
Mais comment?
But, for example, what Dr. Koivu said, how do you take her comments on safe supply?
Mm-hmm. Yeah, thank you for that. And, we, our evidence has shown it reduces overdose deaths. And there is in other, and I'll point to kind of other studies where it has not shown to increase rates. Rates of addiction are not increasing since we reduce safer supply. The description that Dr. Kovo gave is about this kind of ever, escalating kind of need for increasing dosages. That's not what I see happening in the way that prescribers here in British Columbia are practicing. And in fact, in our study, we found that safer supply medications were often at least in the first 18 months, at a lower dose than traditional opioid agonist treatment. And, I do a lot of qualitative research, and I interview people who are receiving safer supply, and I often ask them about their goals. And I would say that frequently what they talk about is the goal of getting off safer supply. And that might include, using safer supply for a period of time, maybe transitioning to OAT. But they have a plan because they too want to live to, a full and high quality of life for that. So, those are the kinds of things, those kinds of goals are, I think, really important. And I'll just, that's some of the reality of which I see here within the work that I'm doing. Thank you.
Thank you, Dr. Pauly. Next, Mr. Johns, please, for 6 minutes.
Thank you. Thank you all for your testimony. Maybe I'll start with you, Dr. Pauly. You heard from Dr. Koivu. She raised concerns around infectious complications for people using safer supply. Is this something you found in your research, people that were injecting fentanyl and then they switch over to safer supply, or people that are starting on safer supply? Is this what you're seeing in your research as well?
I'll give you kind of a bit of a I think, background is that, when people are injecting from the unregulated and toxic drug market, there are additives, and my colleagues on the panel have spoken to this, and, how harmful those additives in the unregulated market are and often cause, abscesses and injections. And I believe that the committee had a brief submitted to you from Dr. Gomes, who looked at administrative data for people receiving safer supply, and this was in Ontario, that the actual rate of infections went down when they went into a safer supply program because they were no longer injecting toxic substances from the unregulated market, but they would have also had a connection to healthcare, and that's a really positive outcome of safer supply types of programs. And so in British Columbia, we have more injectable formulations. So if there is a concern about injection-related infections, which may be why those are being used more in British Columbia.
Dr. Koivu, given what Dr. Pauly said, could you please submit your own research to this committee that supports your claims on infections caused by hydromorphone within 14 days? Is that the will of the committee to get support for that? Yeah? The witness agreed?
I can.
Mr. Chair?
Well, if you've asked her to provide it and she agrees to provide it, I don't think you need everyone else's opinion.
On the record. Thank you so much. In terms, I'm going to go to Ms. Hopkins, and you are co-chair on the expert task force on substance use, and the expert task force was unanimous in recommending that that we scale up safer supply, that we scale up, that we stop criminalizing people who use substances. Ramp up treatment on demand, recovery prevention, and education, and you had a wide, a really wide spectrum on the expert task force on substance use. Can you speak about maybe your disappointment about the government not following through with the recommendations, and just your experience about how important it would be to reinstate the expert task force and to implement those recommendations?
Yeah, we're talking about using evidence, and the question is about whose evidence is more credible. That's quite a common conversation when it comes to First Nations people whose worldview and culture-based evidence is typically set aside. But that does not mean that, for example, culture and safe supply are like completely incompatible. Safer supply is one more tool in the toolbox. There is no silver bullet. There is not one medication. There is not one strategy, method, or form of care that will solve the opioid crisis or the toxic drug supply. There are many, many strategies that have to be used together in combination.
I don't know if the question was heard properly, and I apologize for that. I just in terms of we just heard from the First Nations Leadership Council and the BC First Nations Justice Council, and they're calling for an emergency cross-governmental and multilateral strategy that ensures the safety of people who use drugs. And Dr. Sayers, a BC FNJC council member, says the toxic drug crisis needs to be treated and addressed as a public health issue, not a criminal justice issue. And yes. Chief Grant Stewart also said it's very much wrapped in the destructive impacts of colonialism, right now, how we're proceeding. Can you maybe add to your thoughts on those statements?
Yeah, I just want to emphasize the importance of safer supply, that's one tool that needs to be available to everybody. In addition to understanding the context of First Nations people, as I said earlier, we do not have community-based resources necessary to address the impacts of opioid toxicity or the toxic drug supply. We don't have services close to home where people need them when they need them. And that often leads them to, moving, traveling off reserve for periods of time. And often the crowd that they most find welcoming are crowds that are involved in selling illicit drugs. That comes back into community. And now we create a new relationship that has significant impact on families and on the whole community. For the first time ever, First Nations communities are reporting murders in their community, not by First Nations people murdering First Nations people. It's by gangs coming from large urban environments onto reserve and committing these crimes. Gun violence, human trafficking has increased. And if we look at, what is the perception of that? We could say, well, there are, because of racism in Canada, First Nations people will be blamed for those kinds of activities. They did this to themselves. But that's the same sentiment of people who use drugs. They should just stop. They can just decide. Why don't they choose something different when they're losing all these things? We're blaming the victim without supporting their right to health and social services. The United Nations, sorry.
Thank you, Dr. Hopkins. Ms.
I'll
Goodrich, please, for 5 minutes.
Thank you, Mr. Chair, and I want to thank all the witnesses for being with us and being patient. It's unfortunate that Chief Frost did have to leave us before we got a chance to questions. I found her testimony to be incredibly insightful. Dr. Pauly, did the study you cited look at diversion as an issue?
Yeah, thank you. That's such an important question because that is definitely an issue that is, I would say, creating the most controversy. So I will speak to two ways in which, while the study didn't directly look at diversion.
Okay, so it didn't look at diversion.
No, I will explain.
Yes or no? We've got a very limited amount of time, and I asked a very short question, and the convention in this committee is that typically witnesses answer for about the same amount of time that the question took. So did diversion get looked at?
Diversion was not apparent because there was a dose-response relationship. In other words, if people got more days of the medication, there was less risk of overdose, which suggests they were taking their medications, and there was a dose sensitivity relationship, higher doses, less risk.
Thank you.
So what this leads to is that people were taking their meds in many cases.
To Dr. Koivu, I'm sure you've seen the proposals that are coming out from the City of Toronto asking for a proposal to move towards a decriminalization for that city. Do you think that would have impacts on communities like London?
I think that anything that happens in Toronto is definitely going to have impact on London. And what we're seeing in London itself has been largely affected, I think, by decriminalization as it is. We're certainly seeing a lot more open drug use, a lot more, very common to see people injecting in parks and smoking fentanyl in parks and injecting Dilaudid in public spaces already. So I would think that would be something that we would have a problem with, yes.
Thank you. So really quickly, have you seen a change in the drug deaths in London since the so-called Safer Supply program came in?
Absolutely. I don't know how to answer that really quickly, but the first thing I'll say is in 2016, our overdose deaths were equal to the province. Since 2016, in 2022, where I have information, the provincial rates went up by about 2.7. London's went up by almost fourfold, so a significant increase in overdose deaths compared to the provincial average, and a significant increase in overdose deaths compared to the other community I work in, which is just south of there, which had exactly the same in 2016 and now continues to have the same as the provincial average. The other place where I see significant changes is in youth. If you look at the youth population, and this data is all available on the Public Health Ontario's opioid tool, that people 15 to 24, London's was lower than the provincial average in 2016. Now it's substantially higher, same with people 25 to 44. So when I'm looking at people that I would consider young, that there has certainly been an increase in deaths. The thing about Ontario often, also the other thing is hydromorphone is absolutely more common, over twice as common to find hydromorphone in deaths in London than the provincial average. Often the provincial averages dilute things, and if you go to Ontario, you can actually look and find that where safer supply has been available, there are increases over provincial averages.
Thank you. I appreciate that. And now I'm going to move a motion that I put on notice on Friday, Mr. Chair, and it's that the committee invite the Minister of Mental Health and Addiction and the Associate Minister of Health before the committee for no less than 2 hours, and that the study of the opioid epidemic and toxic drug crisis in Canada be extended by 6 meetings to invite further witnesses. Mr. Chair, I think it is absolutely incumbent on us, as we've been hearing testimony and seeing the entire situation shift, that we have more witnesses come so we can explore some of the public safety and other aspects that we have not been able to fully explore through this committee. I do understand that we've perhaps had some conversations about having some amendments, and with that, I will cede the conversation.
Thank you, Ms. Goodridge. The motion is in order. The debate's on the motion. Dr. Ellis has the floor.
Thank you very much, Chair, and I appreciate the comments from my colleague and the need to continue this discussion. And I think it's important for Canadians that we underline the fact that there is some controversy that exists here, not all of it based in science, much of it based in opinion, which is not necessarily helpful in an argument in where we do know there is good scientific arguments based, which many of my colleagues may not like the fact that it does exist, but it does exist. And also, I think it's important to continue on this road to enable this committee to understand that some of the science that has been referenced here does not answer the questions that we need answers to. I think it's also important that we understand that the government of British Columbia has asked for an end to the decriminalization experiment, certainly outlined by communities such as New Westminster, Richmond, Campbell River, Kamloops, Sicamous, and that as Canadians hear more and more about the experiment that has been undergoing here, Canadians are fearful for their own communities. They're fearful for their communities because of contamination from used paraphernalia. They are concerned because of the potential for exposure to drugs by children. We've heard even by pets in some areas. And the other thing that I've heard directly from Canadians is that they are concerned due to the loss of accessibility of their downtowns. And that is also a concern that we heard very clearly from the Deputy Chief of Vancouver, who testified at this committee not that long ago, who made it very clear that the decriminalization experiment has led to loss of downtowns and use of substances outside of businesses, outside of residences, on transit, near schools, parks, beaches, etc. And the Deputy Chief's testimony really related to the fact that police were powerless to stop this type of activity. So we also know that the Minister of Mental Health and Addictions has spoke very forcefully about this in the House of Commons and in the media, attempting to explain away the request by the government of British Columbia to end the experiment. And I find it interesting because it was the government of British Columbia that came to the federal government asking for the experiment, understood that. But we all know, even though this is not scientific in a sense, but when an experiment is going awry and the people in charge of the experiment say, we need to end it, then it needs to end. And when you are doing a scientific experiment, such as a randomized controlled trial, when those lead investigators understand that something has gone awry, they don't continue the experiment. They stop it. And they don't wait for days and days and days to stop it. They stop it immediately when there are those signals out there. And I'm very, very disappointed in the NDP Liberal government, and specifically in the Minister of Mental Health and Addictions, that the British Columbia government has asked for the experiment to end, and now there are negotiations with the NDP Liberal government to continue the experiment. Which again, if we want to talk about this, even though I realize it's not scientific, but if we want to use that metaphor, then we know clearly that the experiment must end now for the betterment of this country. Because it's a failed experiment. We've heard that over and over and over here. We know it's a failed experiment. The BC government knows it's a failed experiment. And the question that I have is, when will the NDP Liberal government know it's a failed experiment?
Point of order from Mr. Johns.
Point of order, just for clarification, the BC government has not asked to stop decriminalization in British Columbia.
Thank you.
They have made
Mr.
Point of order.
some
Thank you very
changes,
much.
and I just want
point of order.
also, Mr. Chair, I think it's been well
colleague,
it's been ruled
Thank you
by
very
the
much, Chair. So when my colleague wants to have the floor, he can raise his hand and have his turn. He should know that. He's been here long enough, even though that he perhaps is ideologically motivated by his wacko comments. Then we need to continue on with this.
Mr. Chair?
So that being said...
Point of order. Mr. Chair, it is completely unacceptable for a member to be calling another member wacko, and that is completely unacceptable. You know,
Mr. Johns, please contain yourself. He said that your comments were wacko, which may be unpleasant to hear, but it wasn't an attack on you. And your interruptions do not constitute points of order. I would ask that you wait your turn. You are on the speaker's list. You're third. Dr. Ellis, go ahead.
Thank you very much for that, Chair. And, you know, I don't mean to disparage the member. As I said, his comments are wacko. And I think it's important to understand that the citizens of this country are no longer wanting to tolerate ongoing difficulties with the experiment, as it has been termed by my friend and colleague, Dr. Handley from the Liberals, as the experiment from the outset, which was part of the motion of this study here in Health Committee. I'll end my comments there. Thank you, Chair.
Thank you, Dr. Ellis. Madame Brière, s'il vous plaît.
Merci, Monsieur le Président. D'abord.
Thank you, Mr. Chair. Dr. Ellis is mixing up the use of drugs in public spaces and decriminalization, and BC has not asked for the end of decriminalization, but rather to review their request, considering the motion and considering that the minister has appeared before the committee, and there will be a committee of the whole at the House by the end of the month, and considering the trip that we will be doing next week, and during which we will meet people on the field and we will be able to ask them all of our questions. And so I would propose to amend the motion, and then it be read as follows: that the study on opioids and drugs be extended by 2 meetings to invite further witnesses.
An amendment. The amendment is in order.